My name is Dr. Jonathan Rosenberg, and I'm a medical oncologist at Memorial Sloan Kettering Cancer Center in New York, and I focus on bladder cancer. We know that patients with advanced urothelial cancer have poor outcomes, and particularly in patients who can't receive platinum-based chemotherapy. For those patients, they're able to receive immune checkpoint inhibitors, PD-1 and PD-L1 inhibitors, as first-line therapy because they're not candidates for systemic chemotherapy. However, the activity observed to date as single agents has been less than what we'd hoped, and so new options are needed, and we hope that combining with novel agents will improve outcomes in these patients. Uh, it is known that urothelial cancers harbor mutations in DNA repair genes. About 24% of patients' tumors will have these mutations. In particular, it appears to be linked to poorer outcomes, worse outcomes in advanced urothelial cancer. And some of these defects render tumor cells susceptible to PARP inhibition using PARP inhibitors. And so we then conducted a phase 2 study to determine if olaparib, a PARP inhibitor, improved the activity of durvalumab in untreated platinum-ineligible metastatic urothelial cancer patients who had not received prior chemotherapy. This was a randomized phase 2 study that was placebo-controlled and double-blinded, with the primary endpoint of the study being progression-free survival. The primary endpoint of the trial was progression-free survival by RECIST 1.1 in the entire study population. Patients were randomized and stratified based on mutation status, as well as Bajoran risk index. And they were randomized to durvalumab and olaparib or durvalumab and placebo. And the primary endpoint, again, was progression-free survival, with secondary endpoints of overall survival and progression-free survival in the HRR, the homologous recombination mutation group of patients. And so the data was looked at both in the entire population, the primary endpoint, as well as the HRR mutant patients only. The main results of the study showed that there was no difference in the overall population in progression-free survival between patients treated with durvalumab and olaparib or durvalumab and placebo. We saw that the hazard ratio was 0.94, and the median progression-free survival was 4.2 months and 3.5 months, which with olaparib and with placebo, respectively, and did not meet statistical significance. However, in the subgroup of patients who had HRR mutations in a pre-specified analysis, there was a significant increase in progression-free survival in patients treated with durvalumab and olaparib compared to durvalumab and placebo. And the difference was fairly large, almost 4 months improvement from 1.8 to 5.6 months with the addition of olaparib, with a hazard ratio of 0.18, which is a very, very strong hazard ratio. The number of patients in this subset were about 20% of the patient population in the study. And so a small subgroup of patients compared to the entire trial, but this was highly significant and provocative, suggesting that perhaps we might see benefits in patients treated with durvalumab and olaparib if they have HRR mutations. Of course, this would need to be tested in a subsequent trial. The data for overall survival showed, as we also expected, that patients with HRR mutations on average did worse, although, and that the study was not powered for survival. We did not see significant changes in survival between durvalumab and olaparib or durvalumab and placebo. But again, the sample size was very small in this clinical trial overall for survival. I think this is a good demonstration of concept that targeting these DNA repair mutations in urothelial cancer may be relevant in combination with immunotherapy. Previous studies that had been reported before had not selected patients based on HRR mutation status, and when you do that in the pre-specified subgroup analysis, we've shown that this population seems to do better in terms of progression-free survival. It's unclear whether they do better yet in overall survival because that was not the endpoint, that was not powered to do this. Um, so the next step would be a potential larger randomized trial in that selected subset. And I think that the data warrant that in advanced urothelial carcinoma in combination with immunotherapy.